I think we're good to go.
Okay.
The broadcast is now starting. All attendees are in listen-only mode.
Hello, Kelechi.
Yeah, good day, everyone. Can everyone hear me? We would like to start this webinar now. I'd like to welcome and thank you for joining this webinar today. I'm Professor Kelechi Noham, and I'm the president of Public Health Foundation of Nigeria. I'm very pleased to welcome you all to today's webinar. Today's event is brought to you by the Public Health Foundation of Nigeria, PHFN. The mission of PHFN is to improve the health of the Nigerian people. And with this mission, we aim to influence public policy formulation for health in Nigeria and increase capacity in the Nigerian public health system. To fulfill our mission, PHFN pursues the following strategic objectives that I'll just quickly highlight almost in a bullet point fashion. Advocate evidence-based public policy for Nigeria, building professional, organizational, and system capacity for public health, creating and sustaining peer support for Nigerian public health professionals, re-energizing the Nigerian health community in the diaspora to engage with the health sector in Nigeria, creating a forum where Nigerian health professionals working in the diaspora and partners working on health issues in Nigeria can share ideas and opportunities, and meet and explore opportunities for working together on projects that will influence the health of Nigerians. Now, before we begin the presentations today, I have a couple of quick announcements that I think are really important. This session is being recorded, and it will be available via the PHFN website, that's www.phfn.org, in approximately 1 week's time. All participants will be muted throughout the entire webinar. And there is a lot of content to cover within this 90-minute session, including a few question and answer sessions. You may submit questions and comments at any time during the presentation. I'm mindful we have already received some questions that we will play in the course of the conversation. But you have the opportunity to submit questions and comments at any time during the presentation by using the question dialog box in the tools panel on the right-hand side of your screen. So coming to the webinar itself, it's my great pleasure to introduce the three speakers for today's session. Our first speaker, Professor Oye Gureje, is a professor of psychiatry and director of WHO Collaborating Center for Research and Training in Mental Health, Neuroscience, Drug and Alcohol Abuse in University of Ibadan, Nigeria. He's the member of the WHO International Advisory Group for the revision of ICD-10 chapter on mental and behavioral disorders. He chairs the work group on somatic distress and dissociative disorders and is vice chair of the Field Studies Coordinating Group of the revision exercise. He's a past president of the Association of Psychiatrists in Nigeria and of the African Association of Psychiatrists and Allied Professions. Professor Gureje is a member of the editorial board of several journals, including International Review of Psychiatry, Social Psychiatry and Psychiatric Epidemiology, Drug and Alcohol Dependence, Epidemiology and Psychiatric Services, and Lancet Psychiatry. He's been active in global mental health for over 2 decades, with leadership roles in several collaborative studies in epidemiology, randomized controlled trials, and health systems strengthening. He does play a leading role in mental health policy development in Nigeria as chair of the Federal Ministry of Health's Mental Health Action Committee. In 2008, he was conferred with Nigeria's highest award for academic achievement, the Nigerian National Order of Merit, by the country's president for his contributions to medicine. It's a real pleasure to have Professor Oye Gureje on this webinar today. Our second speaker, Professor Makanjuola, obtained degrees in physiology in 1966 and in medicine in 1970 at the University of Ibadan, Nigeria, and a PhD in 1978 from the University of Edinburgh in UK. He obtained his specialist postgraduate qualification, the membership of the Royal College of Psychiatrists in 1975. He's also a fellow of the Royal College of Physicians of London, UK, the West Africa College of Physicians, and the National Postgraduate Medical College of Nigeria. Roger spent the greater part of his working life on the academic staff of Obafemi Awolowo University in Ile-Ife, Nigeria, and as an honorary consultant in its associated teaching hospital, the Obafemi Awolowo University Teaching Hospital Complex. He was appointed a professor of psychiatry in 1984. He served as chief medical director of the OAU Teaching Hospitals Complex from 1989 to 1997. He was appointed acting Vice Chancellor of the Obafemi Awolowo University in 1999 and then Vice Chancellor of the university from 2001 to 2006. He has also served as President of the West African College of Physicians from 2007 to 2008 and Chairman of the Medical and Dental Practitioners Council of Nigeria from 2010 to 2011. Professor Makanjuola has published a book titled Water Must Flow Uphill, which describes his experiences when he was head of the teaching hospital and subsequently the university at Ile-Ife. Our third speaker is Mr. Egwu Chiijoke. Egwu Chiijoke is a law graduate of the University of Nigeria. His first episode of mental illness occurred sometime in his early teens, and this lasted about 6 months. He was able to regain his health after this and complete his secondary school education with distinction. In February 2004, as a university student, he experienced a relapse of his mental illness. Egwu ended up destitute and on the streets of Lagos State in Nigeria, where he was for nearly 5 years. In 2009, with the help of his family and the Amudo Community Mental Health Project situated in the southeast of Nigeria, he received treatment for his illness and again became better. He then got readmitted to university to continue his law studies and has since graduated. Egwu Chiijoke is the author of a book titled 100 Golden Poems on Nigeria's Centenary, a book of poems published to celebrate Nigeria's 50th anniversary celebrations. His law degree thesis was on the assessment of the adequacy of Section 28 of the Criminal Code Act and other laws protecting the rights of the mentally ill person in southeastern Nigeria. On the occasion of this year's World Mental Health Day celebration, Egwu presented a paper at the Amudu Comprehensive Community Mental Health Program in Abia State, Nigeria, titled Dignity in Mental Health, the Role of People Living with Mental Illness. Egwu is an active presence in mental health-related forums in southeast Nigeria, where he avails audiences of his experiences as the former sufferer of mental illness. He's also a motivational speaker on speaking circuits. It is my pleasure to have these three distinguished speakers on this webinar today. And without further ado, it is my pleasure to turn this call over to Professor Gureje to start his presentation.
Well, thank you. Thank you very much. It's a real pleasure to be a part of this panel for this webinar. And I would like to start by really expressing my deep appreciation to the Public Health Foundation of Nigeria for putting this together. What I'm going to be talking on the first part of my lecture is on, so can we get this slide moving now so that I can get to the, so I will be talking on the current state of mental health care in Nigeria, and in doing so, I will be reviewing briefly the extent of the mental health problems in the country, and then providing an answer to this question of whether mentally ill people are actually getting the care they need, and if not, what are the barriers that stand in the way of meeting the treatment needs of such people, and what can be done to bridge the treatment gap. So we'll start with the evidence of burden, which comes from a variety of sources. They come from primary care settings, they come from where people live in the communities. The first slide that I'm showing here is a slide with the result of a big study that was done in primary care about 2 decades ago actually now. I am showing this slide because it is one that sets the stage in terms of how common mental health conditions are across several settings in the world, and Nigeria just happened to be one of those countries where the study was done. And as can be seen on this slide, about 10% of people consulting primary care settings in Nigeria will have one mental health condition or the other, with depression being the most common. So 1 in 10 of primary care attendees present with or have a mental health condition as one of the health challenges that they may be facing. In regards to, that's about adults. The same is also true for adults, for children. A study that we did several years ago now, in again another large study conducted in primary care, pediatric primary care, we found that about 20% of children aged between 7 and 14 will meet the criteria for one mental health condition or the other. Again, the common ones being depression, conduct disorder, and anxiety disorder. So these conditions are as common in adults as they are in children attending primary care settings. In the community, the best example we can give is the one that has included the largest sample of Nigerians in a study, the Nigerian Survey of Mental Health and Well-being, conducted a few years ago in several parts of the country. And that study showed that the lifetime prevalence, that is, at the time of study, at least 12% of the respondents had experienced one mental health condition or the other at the time of the study. What's interesting about the study or the findings was that we projected what the prevalence would be by the time people would have achieved or attained the age of 75. We found that about 20% of people will have at least one major mental health condition at the age of 75. So that was a study conducted in the general public and among community resident adults. What's important about that is also the extent to which this rather unstated or understudied problem of suicidal ideation and plan and attempt was quite common in this sample of over 6,000 people, where we found that almost 1% of the people, of those responding to this study, who participated in the study, had actually made one attempt at killing themselves, 0.7%. This is actually not quite different from what has been found in many other countries. And about over 3% of the people have had thought of killing themselves, which is suicidal ideation at the time the study was conducted. Again, that was in general adults. Another large study, this time conducted among elderly people, 65 years and over. Again, larger studies of that nature conducted in this part of the world, by the study of aging, showed quite high prevalence of mental health conditions, this time depression, among the elderly. Again, you see on this slide, about a quarter of the sample had experienced a major depressive disorder in their lifetime, and about 8% had done so in the previous 12 months by the time the study was conducted. Also quite a common occurrence, depression among the elderly. And this slide, again, reemphasizes what's been found in many other settings, which is that this condition is more likely to be, is more common among women than among men, with a significant level of difference between the two groups. Now, these conditions do have consequences for the people who suffer from them. We have evidence that people with a variety of conditions in primary care, mental health conditions in primary care, are more likely to be experiencing poor overall health than those without such conditions. They are more likely to be disabled in the performance of their occupational role, this day-to-day role. They are more likely to report disability days in the previous month, that is, days where they were unable to perform their roles, unable to go to work, unable to meet their parental role or role as students. And these conditions are often chronic, with about 18% of people who reported having the condition when they were followed up 12 months later were still experiencing the same condition. So there's quite a significant level of chronicity associated with this condition. As I've mentioned, suicide is very common, and we found that this is actually very much associated with many of those common mental health conditions. So there was a fourfold increase of suicidal attempts among people with anxiety disorder, a sixfold increase among people with substance use disorder, and 18-fold increase among people with depression. That is compared with those who didn't have any of these conditions at the time of the study. Now, significantly, mental health conditions are much more disabling than a lot of the common physical conditions. As shown on this slide, in the study of aging, we found that people having, elderly people having depression were more likely to have, to be rated as being severely disabled than those with arthritis, those with back and neck pain, those with high blood pressure, those with asthma, and with diabetes. Again, this is not an uncommon finding in most part of the world where this kind of study has been done, that mental health conditions tend to be more disabling than the more common, the common physical conditions, both in the elderly and the general adult population. So I've mentioned this already. There's fact that people are more likely to be experiencing poor overall health, and that the fact that mental health condition has implications for overall national development. As shown in this slide, part of the information obtained in the National Survey of Mental Health and Well-being was the fact that the average person who had a mental health condition had lost an earning that was equivalent to about 60,000 naira in the year prior to the study. And if we, when we computed this on a national scale, it translated to an annual loss of about 21 billion naira for the country. This is in terms of productivity and lost earning, not in terms of direct spending to procure heads, to procure medication. This is in terms of loss of productivity, inability to earn what people with equivalent degree or equivalent qualification or skill was able to earn. Now, in responding to this large treatment at large body in the country, we've had several attempts made at the national level to provide mental health service. This slide is just sort of a brief historical summary of important service landmarks in the country. The establishment of asylums in Calabar and Yaba many years ago, and the development of more modern facilities in Aro and Abeokuta, departments of psychiatry in teaching hospitals across the country. And as we all probably will remember, the pioneering effort to take service out of institutions by Professor Adeyo Lambo in the Aro village system. Also, community service been rendered in sort of sporadically. An example of that is that of Ogun State by Dr. Ayoride. An important milestone was the establishment of 8 neuropsychiatric hospitals in the early 80s to complement existing facilities at that time. So some major efforts have been made to meet the need of mental health conditions in the country, but large unmet needs persist. By the result of the national survey that I just mentioned, we found that only 10% of people who had a current mental health condition had received any treatment in the previous 12 months. And out of this, only about 10% could actually be said to be receiving anything that could be described as adequate treatment. That is, a large number of people who were receiving treatment were actually receiving treatment that was unlikely to alleviate their suffering. And among those who received any treatment, there was often a big lack in the delay between the time the illness started and the time they received their first the first treatment. The treatment delay of an average of about 6 years. Again, this is a dramatic evidence of the treatment gap that exists in the country as obtained in that national survey a few years ago. The same thing was true in the study of aging, which I mentioned before. Among the elderly people who had depression, only 36% of those who had experienced this condition in their lifetime had received any kind of treatment at the time of the survey. And again, there was a mean delay of 5 years between the onset of the condition and the receipt of any treatment by those who did. The important thing is to emphasize that even when care is sought by people with mental health condition, there's often an inability of those who should be able to provide this care to detect the condition. So in primary care study, we find that primary care providers are often unable to detect the presence of mental health conditions. And of course, when they do, as I mentioned, the treatment that they provide is often inappropriate or inadequate. For example, for people with quite a significant level of depression, hardly will you find antidepressants being prescribed for them in the primary care setting. So the question is, why do we have so much unmet need? Part of this is due to a systematic general problem with the National Health Service. That is in general, not just with mental health condition, but also some specific problems with mental health service. Among these, of course, are the problems relating to lack of knowledge, poor knowledge, and poor attitude, which is shown by the high level of stigma in the community. And of course, the import of this is that people will often not be able to or ready to seek care because of the fear of being stigmatized. And so there will be often a delay in seeking treatment. We have evidence of how large this problem is in the community. On this slide, you will see that more than 40% of Nigerians believe that mental illness is due to supernatural causes, possession by evil spirits or punishment by God, and over 30% believe in religious magical cure, which of course will mean that for those people around them or for they themselves, they will not turn to a healthcare provider to alleviate their mental health problem because of the way that they perceive the problem. This level of stigma, even compared to the level of stigma among those with chronic physical condition, is quite striking. Again, you will see here that people who have mental health conditions who reported having significant, experiencing the significant level of stigma, about 35% compared with only 9% among those who have chronic physical condition. And that's not to say that stigma is not confined to mental health conditions, but it's a more significant barrier for people who have such conditions. Now, access to care is limited. This is going to be elaborated on by Professor Makanjuola. The fact that we have about one psychiatrist to a population of about 800,000 people, and that this ratio is actually worse for other mental health professionals, clinical psychologists, social workers. They are actually much fewer than psychiatrists in terms of the ratio. Psychiatric beds are few, and the few existing psychiatric hospital or psychiatric beds are located in mental hospitals rather than in the community far away from where people live, and so limiting access to them. And as I've mentioned, the primary care workers who should be providing the bulk of service lack adequate training to identify and to detect and treat common mental health conditions. So people resort to faith healing and traditional healing homes. For example, a mapping exercise that we did recently in Ibadan showed that about 87% of these traditional faith healers are around the city of Ibadan, provide admissions for their patients. But the important story about this is really that across these facilities, we had about 430 admission facilities, or what you might regard as beds, admission beds. But if you compare that to just 90 beds available in the public health system, then you will see that the bulk of the service, there are people who receive any treatment at all, where the bulk of the treatment is provided by traditional faith healers. Again, that has implications because in these various facilities, the experience of abuse is very rampant. Shackling is a very common problem. Beating, scarification, and all sort of harmful practices. Of course, there is also the problem of poverty constituting a big barrier to accessing care because people pay out of pocket, and we know that out-of-pocket payment is a most regressive way to pay for health, and this, of course, limits access to care for people who do have it. Policy gap. Everything we've said has to do with the fact that mental health service is receiving very little attention at the policy level. Even though we had our first mental health policy promulgated in 1991, it was really never implemented. And we now have a second revised version of that, which was adopted by the National Council of Health in 2013. And we're just hoping now that maybe the government will pay more attention to the implementation of this policy. But so there's a big policy gap. And that, of course, is reflected in the poor funding of health. In fact, in Nigeria, there's no specific mental health budget. All we have a budget for salaries in the existing service facilities. So no programmatic budget for mental health. All right, so what can we do to help to make the situation better? We have experience about what can be done. We have been conducting a service scale-up program using a new tool developed by the World Health Organization in the state of Osun. We've been doing this since 2010, including, and part of that include the engagement with policymakers, training of primary care providers to be able to detect and treat mental health conditions better, and also to do some public enlightenment activities. The result of this has been quite dramatic in terms of the number of people who have turned up to receive care, especially for conditions that have often resulted in their being locked up or they are being confined and shunted away from the public. A competition like epilepsy and psychosis. So we have also noticed that these people, the primary care providers, can actually be trained to deliver this service, and they can show, they can acquire the skill, and they show show competence in the delivery of care. Luckily, or well, fortunately, this has also not gone unnoticed by policymakers. It has led to the adoption of the Mental Health Gap Implementation Plan by the National Council of Health in 2013, showing that if we do something at that level, government might be able to pay attention and do something more concrete. So the lessons we've learned from this is that we need to remove the filters to recognition and treatment through public education, through properly conducted training of primary care providers so that they can deliver quality service. We need to engage with policymakers to improve attention to mental health service. And of course, we need to deal with the problem of ability to pay, perhaps through the institution or inclusion of mental health conditions in the national health scheme. We need more research, of course, in order to provide more evidence for what needs to be done in terms of how to reach more people and how to deliver effective interventions. And there also, of course, to do more advocacy, especially at the national level, for more attention to mental health service. The last slide that I have here is really to emphasize some of those gaps that need to be bridged in order for service to be improved. Implementation of the policy and enactment of the mental health bill, and of course changing the attitude of professionals themselves to be ready to do what is required to train primary care providers. Thank you very much.
Thank you very much for that extremely insightful presentation, Professor Gureje. Really interesting to notice the scale of unmet mental health needs in Nigeria. As you can imagine, there's a lot of questions that are coming in here during your presentation, and I've just noted that some of them may have been answered toward the latter part of your presentation. But can I just spend the next 3 minutes that we have on a quick Q&A to just pick out one or two questions that I'd like you to just dwell on. There's a question here that reads from Femi Adebajo. It reads, what effects do the iceberg phenomenon, restricted access to health care, reliance on faith healers, unorthodox practitioners, quacks, and willful concealment of mental health disorders due to fear of stigma, what effect does all of those have on the results of psychiatric epidemiological surveys in Nigeria? Do you want to just reflect on that for a moment, Professor Gureje?
Oh yeah, that's a good question actually. Because mental health conditions, when we do the studies identify their presence, we have to rely on people self-report, and we have to be able to, people have to report that they've experienced so many symptoms that can be put together to constitute a disorder. There is no doubt that their views about those symptoms, either cultural views or views around the stigma that reporting of those symptoms may constitute, will certainly have effect on how many of those symptoms they will report, and of course will have effect on whether they will reach the level of diagnosis or not. So certainly some of the epidemiological findings or reports that we have made from Nigeria, we've also always added that caveat that the estimates are very conservative because of the possibility that due to stigma, due to lack of knowledge, due to many other factors, people might not have always reported all of the conditions they might have experienced. Then, of course, people need to be aware of what are the symptoms of mental health disorders in order for them to, in fact, report them when they are not taking part in research activity. For example, if we were to use access to care as a way of showing what level of what's the prevalence of mental health conditions in the society, we will be having very imprecise estimate, because only a tiny minority of people will be seeking care, not just because of this care facilities not being available, but also because of their own perception that what they have may have nothing to do with mental health. And as I mentioned, I showed in one of the slides there, people may also attribute some of the symptoms to non-medical causes, and say they are sort of curses, they are religio-magical attributions, which may of course limit the possibility that they will in fact go to a facility and be counted. So there are many factors that will have a bearing on the estimates that we provide, and so any of those estimates, they've got to be seen as being very conservative indeed in terms of their how close they are to reality.
That's really helpful, Professor Gureje. I know we're really pressed for time, but I can tell you the quality and the numbers of very interesting questions we're having. Can I just ask you over the next 1 minute or maximum 1.5 minutes to reflect on a number of questions I'm going to try to condense into. As you can imagine, there's been a lot of questions about stigma and what we can do to reduce stigma related to mental ill health. I know some of that you've covered, but can you just reflect for a little moment on that one, because there's so many questions coming on that if there's any other thing you wanted to say on prevention of stigma, that would be helpful. But in addition to that, one other question that is a more direct question about integration of mental health mental health prevention in schools and what we might be able to do around those. Could you just reflect very briefly on those before we move over to the next presentation?
Yeah, so very briefly, the first thing is to acknowledge that even as mental health professionals, we have we accept our poor knowledge about the most effective way of tackling stigma. There have been many studies conducted. We really do not have a firm grip on what will be the main components of an anti-stigma, an effective anti-stigma drive. But nevertheless, there are things that we think are helpful in some ways. And one of them is what you mentioned, integration of mental health service into routine care and into routine delivery of service in primary care, expansion of knowledge among children, among school-going children, and of course public enlightenment. These are basic things that that seem to have some impact on the reduction of stigma. But I would say this with the acknowledgement that we actually know that, I mean, even in countries where some of these things are very much in operation, there's still quite significant level of stigma. So we do recognize that this is a really big battle that needs to be fought, but for which we don't have effective weapons at the moment.
Thank you very much for that, Professor Gureje. Without further ado, I'd like to move on very quickly to Professor Makanjuola's presentation. There is a number of questions that came during your presentation, Professor Gureje, on mental health workforce. So because that fits very nicely into Professor Makanjuola's presentation, I'm going to ask that we'll listen to Professor Makanjuola's presentation, which I think would address a number of those questions. But if not, we'll make sure that that's picked up in the presentation. So could I hand over to Professor Makanjuola to give his presentation on the workforce situation in mental health care delivery in Nigeria?
The screen is not moving. Thank you. I want to thank the Foundation for inviting me to make this presentation, to participate in this webinar. I feel greatly honored. I've been asked to address the issue of mental health care workforce in the country. I will expand a little on that subject in order to make the presentation more meaningful. It's not moving, I'm afraid. During their lifetime, 12% of Nigerians will have one or more mental disorders. The 12-month prevalence is just under 6%, which means that during each year, 3 million Nigerians will be suffering from a mental disorder. And out of this 3 million, 20%, over a quarter, are severe enough to warrant treatment, to require treatment, but only a minority, less than 10%, actually obtain that treatment. That's a massive gap. And my guess is that one of the major objectives of this webinar is to address solutions to that gap. How do we reduce that gap between those who require mental health care and those who actually obtain it? Nigerians who require mental health care have access to a variety of sources. Apart from Western medicine, there are alternatives which include home remedies, the traditional pharmacies, a variety of traditional healers, and of course a variety of religious healers. I'm afraid you're less aware of it. Now, we don't have accurate data about the proportions of Nigerians that receive care from the various sources, but there are indications that Western medicine is often not the first choice of care amongst Nigerians. and that they're more likely to seek help from these alternative sources. And I have to acknowledge that these alternative sources do have some advantages which may influence the choice. First of all, these alternative sources are based in the community. They're easy to get access to, unlike a lot of the Western medical facilities, where you have to travel quite a distance to get to them. The other issue, another advantage that the alternative sources have, is that the practices of these alternative sources are more in line with the cultural, religious, and social belief system of Nigerians. In fact, this is something that we need to learn from this, actually of taking cognizance of these cultural, religious, and social beliefs in our own practice of Western medicine. Nigerians, I'm not there yet, anyway, that's okay. There's another issue. Nigerians, a large proportion of Nigerians actually believe that Western medicine is less effective, possibly not effective at all, in the management of mental disorders. And this also tends to point them towards these alternative sources. Which brings us to the question, how effective are these other sources? There isn't an easy answer to that. I will just make one point, which is that those of them that employ medicines, and can you move it? I can't move this for some reason. Those of them that employ medicines do use a variety of agents. And some of these agents have active psychotropic qualities. The best known of these is this plant, Gureje vomitoria. And this plant is called Gureje by the Yoruba. It's used all over West Africa by traditional healers. It contains in its root bark an alkaloid called rezopine, which is actually the first antipsychotic introduced into Western medicine. It was introduced from India in 1949. And that was 4 years before the synthetic agents like chlorpromazine came into online. We don't use rezopine anymore in Western medicine. It's not much, but it is still used widely by traditional healers. Now, the next slide really gives some idea of the distribution of the mental health care institutions in Nigeria. We have 8 neuropsychiatric hospitals. Most of the teaching hospitals have psychiatric units. Federal medical centers, also some of them have psychiatric units. There are, to my knowledge, now only 2 general hospital units. 3 state hospitals have psychiatric units. And there are 3 rehabilitation centers which mainly deal with vagrant psychotics, that is, the psychotics that are taken from the street. Community-based mental health services are gradually evolving, but we don't have figures for this. At least I couldn't find figures. But I will be addressing the issue of community-based mental health services as we go along with this presentation. Most of the services that we provide actually provide secondary care, that is general psychiatry. Tertiary care services, child and adolescent psychiatry, forensic psychiatry, and so on, are very limited and not available in several parts of the country. This thing worked last time I tried. Okay. Now, how many professionals do we actually have in this country? At the last count, we had 210 psychiatrists available to 178 million Nigerians. Just over 1,000 psychiatric nurses. And as Professor Gureje pointed out earlier, the numbers of clinical psychologists psychiatric social workers and occupational therapists is negligible. There really is a major shortage of mental health personnel, not just psychiatrists, but every other cadre of mental health professionals. Yeah, please. And, well, that merely gives the figures per 100,000 of the population, and you can see how low those figures are. Next one. I think there's some issues that we need to note here, which is that these mental health professionals are largely distributed in the south of the country and in the big cities. 6 of the 36 states in the country do not have a single psychiatrist and do not have psychiatric services. One other point I would make is that within our medical schools, psychiatric training at the undergraduate level is often deficient. And this is not surprising, since some universities do not even have a department of psychiatry. They tend to lump psychiatry in with internal medicine. This point is important because when it comes to providing psychiatric care within the primary care system, we're relying to a great extent, to some extent, on general practitioners. If the GP doesn't have the skills, then obviously that care is going to be deficient. Next one. Now, psychiatry is an unpopular discipline, even amongst doctors. This slide gives a comparison of the numbers of candidates sitting the examinations of the West African College of Physicians in 1 year, in a 1-year period. As you can see, psychiatry, which is at the bottom of the slide, is very poorly represented. We have the lowest figures for candidates, apart possibly from laboratory medicine. Next one. Now, why is psychiatry so poorly represented? Well, the last slide illustrated the fact that it's unpopular even among health professionals. There's a stigma attached to mental disorder. And that stigma applies not just to those who have mental illness, but also to those who treat mental illness. There's a famous case of Professor Adiri Lambo, who, when he decided he wanted to go and specialize in psychiatry, he was advised by the then Chief Medical Officer, Dr. Manwa, not to go. He asked him, what on earth do you want to go and do psychiatry for? Can't you find something better to specialize in? There's ignorance. Ignorance of the scope and ignorance of the impact of mental disorder. Many Nigerians equate mental disorder with madness or psychosis. And many Nigerians believe that mental disorder is not a medical disorder, but a spiritual or paranormal one. And that spiritual or paranormal factors need to be used to treat it, not modern medicine. Governments have neglected psychiatry. In the Federal Ministry of Health, there's a mental health desk. There is not a mental health professional manning that desk. There's no psychiatrist there, although they do receive advice from psychiatrists, including Professor Gureje. State governments, none of them have mental health desks at all. And as I said earlier, some state health services do not have a single psychiatrist. Oddly enough, I'm trying to make the point that there's a shortage of psychiatrists, but some of the graduates of our specialist training program cannot find jobs. We graduate specialists, they can't get a job because governments do not believe they need psychiatry. Next one. Let me see if I can get this thing to work. It worked last time. Right. I think it will work now. Right. No, it's not. Okay. Now, the World Health Organization made a report on the mental health system in Nigeria in 2006. And that first line says it all. There is considerable neglect of mental health issues in Nigeria. We have a policy on mental health formulated in 1991. The WHO said it had not been reviewed and its impact had not been assessed. I will go further and say that that policy was not implemented. There is nothing to review and nothing to assess. Essential drugs in short supply. I've already mentioned state ministries do not have mental health desks or mental health section. And they pointed out that only 4% of government health expenditure was expended on mental health. 4% of the total health budget was for mental health. And most of that money, over 90% of it, went on psychiatric hospitals, indeed for paying the salaries of the staff of psychiatric hospitals. Finally, they stated that we have an archaic mental health legal system. I'll come to that later. That this mental health legislation that we employ up to now makes no provision for the human rights of those who become mentally ill. Next one. What's the way forward? Well, we need to increase the resources allocated to mental health and, of course, ensure that those resources are allocated. That 4% has to be increased drastically. But in addition, we need to prioritize how we use the resources allocated to mental health. At the moment, most of it goes on psychiatric hospitals. And I want to make this point very strongly. The entire budgets of all the ministries of health in Nigeria will not provide enough psychiatrists or psychiatric hospitals or psychiatric units to meet the mental health care needs of the Nigerian people. What is required is a system founded on a firm base of primary community-based mental health. A community-based mental health service based within the primary health care system, supported by adequately developed secondary and tertiary services. This was central to the 1991 policy developed during the time of Olikoye Ransom Kuti. We'll never see a man like that again. So what we need is to divert our resources towards implementing a mental health care system with a firm base, firm foundation in the primary care system and adequately supported by secondary and tertiary services. We already, next one please. We have within the healthcare system a huge number, a large number of individuals capable of providing mental health care within the primary mental health care, within the primary care system, provided we train them properly and provide them with the resources they need. Can you go back a slide, please? To the, yeah. This lady is a community nurse. She's practicing in a health center in Ife North local government. She is able now to treat mental health problems. She received training and she has access to a number of drugs, and she can now help to treat a substantial number of common mental disorders. Next one. And that's where she works. A health center, not a psychiatric hospital. Next one. So what I'm advocating is that we should go back to the 1991 policy, recently revised, but the essentials are the same. The primary mental health care system, community-based, provided by primary health care professionals, general practitioners as doctors, community nurses, extension workers, primary care workers generally. And they should be responsible for the diagnosis and treatment of the majority of mental disorders. They will not be able to treat all mental disorders. There will be a substantial number, a proportion that they cannot. Complicated cases, difficult cases. They also have to be able to recognize those cases that they cannot treat and refer them to the secondary care system and possibly then onward to the tertiary service. I would also point out that these primary health care providers, GPs, community nurses, and so on, can also go to people's houses and treat them. Patients who cannot come to the health center or to the general practice can be visited in their homes and treated because they're very close. It's a 100-meter walk to their homes, you treat them there. These individuals will also be responsible for preventive services in the community, public health education, orientation, school health education programs. But I do want to make one point here, which is that within the school health system, teachers also have a role to play. It is teachers that are primarily responsible for school health education, and that should include mental health education. Teachers also have to be trained to recognize the common mental disorders in children, anxiety disorders, ADHD, conduct disorders, and so on. They should be able to recognize them and be able to refer them for appropriate help. So they need to join hands with the primary health care workers in helping to deal with the issue of mental health problems within the school system. Next one. Okay, what do we need for a primary mental health care system? What are the requisites? First is training. We have several thousand professionals working in the primary care system right now. Most of them do not have the required knowledge and skills. They don't have the competencies to carry out this work. For this reason, we need remedial training. We need to introduce remedial training for all of these primary care providers. The WHO has developed this remedial training, and this is being applied in various parts of the country today. That lady, this picture I showed you earlier, received the training. But in addition, we need to make sure that all the primary care providers that are currently being trained, those who are in the training schools, in the medical schools, in the schools of health technology, that we need to incorporate the required knowledge and skills into the basic training, so that when they graduate, they have those knowledge and skills. They have the knowledge and skills to be able to carry out this work. We need to give them the materials they require to do the work, particularly essential drugs. We do have an essential drugs list. It needs to be revised, and we need to make sure that the drugs on that list, as well as the other materials required, are available. Most health facilities in our country at the primary care level do not have adequate supply of these essential drugs. This primary mental health care system needs to be supported by appropriately developed secondary and tertiary care services. They cannot operate on their own. They must be able to refer patients up the line for appropriate care, particularly for those individuals, those cases that they cannot handle. And for this, we need a two-way referral system that works in both directions. We have a two-way referral system within the health care system of Nigeria on paper, but it only works in one direction, up the line. When a patient is sent from the primary care system towards secondary care, it doesn't go back. And as a result, there's an accumulation of patients within the secondary and tertiary care system who don't need to be there. They've been stabilized. Once they're stabilized, they should really go back to the primary care system. But instead, they're all stuck in the secondary and tertiary system. And there's a lot of routine work going on. It doesn't need to be. A patient who has been stabilized and put on a depot neuroleptic monthly injection should be able to receive that monthly injection within the primary care system. Right now, all of them are stuck in the secondary and tertiary care system. Now, I want to emphasize that even within the primary mental health care system, the psychiatrist plays an important role, or will play an important role. It is the psychiatrist that is responsible for supervising services within the primary care system. He is responsible also for teaching the health providers, and he's also involved in consultation at the primary care level. The system that I showed the photographs of, it was set up in collaboration with the teaching hospital in Ife. And every month, from the psychiatric department of the teaching hospital in Ife, a consultant and residents go to the health centers and they consult there. They see patients that are referred to them on site, and they also advise on patients that the primary care providers have some difficulty with. So they do have a very important role. The psychiatrist has a very important role, even in provision of services within the primary mental health care system, or will have when we establish the service. Next one. Now, as I said earlier, we need to develop a firm foundation of primary mental health care. But it has to be supported by adequately developed, appropriately developed secondary and tertiary care services. Right now, most of the psychiatric institutions in the country are providing secondary care, mainly provided from teaching and specialist hospitals and a few general hospitals. In order to develop effective secondary care services, we need to develop psychiatric units in general hospitals in all the states. I'm not sure about the numbers required in each state, but I do want to point out that at the moment, there are only 2 or 3. We need general hospital units, psychiatric units, in all the states, probably more than 1 per state. Tertiary care is very limited in its availability in our country, and it is up to the teaching hospitals to develop true tertiary care services, child and adolescent psychiatry, forensic psychiatry, etc. Next one. Now, we've got 210 psychiatrists currently practicing in the country. we need psychiatrists who provide supervision and consultation at the primary care level. We need psychiatrists within the secondary care system. We need psychiatrists at the tertiary level. Currently, psychiatrists are trained through the fellowship training program of the West African College of Physicians and the National Postgraduate College of Nigeria. The training is a minimum of 5 years, but in most cases it takes 6-7 years, sometimes more. That is a very slow process. It's going to take a long time to produce enough psychiatrists in our country through that process, this long-winded fellowship training program. Recently, the ECOWAS states adopted a new strategy, and Nigeria is part of that strategy. And this strategy is to change the specialist training program in all the specialties, not just psychiatry, into a two-tier system. First tier is a in some cases, 3-year training for a membership diploma, which will become an exit qualification. You finish the membership 2 to 3 years, and you become a psychiatrist. Those who have the membership may, if they wish, enter the next tier, which is the fellowship training program. Again, 2 to 3 years, which will qualify them as a full consultant. Those with the membership will be suitable to practice at the secondary care level, psychiatric units in general hospitals. And as I said earlier, teaching hospitals actually are providing most of them secondary care anyway. But those with membership will practice within the secondary care system. Whereas those with the fellowship are the ones who are going to be providing subspecialty care, child and adolescent psychiatry and so on. And I personally believe that we should convert the fellowship training into subspecialist training. It is at the fellowship level that we should be training the child psychiatrists, the forensic psychiatrists, and so on, and confine general psychiatry to the membership program. If we adopt this successfully, then through the membership program, we'll be able to produce a psychiatrist in 2 to 3 years. And of course, that means we'll be able to create many more psychiatrists for the system. The next one. Yeah, I think we're finished there for the moment, and maybe if there are questions, I can take them.
Thank you very much for that. That's very interesting presentation, Professor Makanjuola. As you can imagine, loads and loads of questions. A lot of questions. Again, I think you were answering as your conversation, as your presentation was going on. But there are one or two that I'd just like you to reflect on for a moment. Just going back to the strategy for medical training that you talked about more latterly in your presentation. There's a question here from a colleague who has referred to another strategy that is similar to, I think what he's suggesting is that one way of ensuring rapidly building up manpower and human resources for mental health in Nigeria is to encourage universities to develop a curriculum for master's degree in psychiatry. Some people might argue that academic degree will not fulfill a professional mental health program offered by a residency program, but he thinks that it's something that public health has adopted, and that has drawn in huge resources into public health. That is something psychiatry might want to reflect on. This question was from somebody called Baba Isa. Is that something you want to quickly reflect on, Professor Makanjuola?
Okay, the master's program certainly is one way of actually addressing the deficiency we have in the subspecialties. Ibadan already has a master's program in child and adolescent mental health. And I personally believe that we should maybe replicate this for other specialties and also in other institutions. The issue would arise as to whether a master's diploma, a master's degree, will be acceptable as a specialist qualification. I believe that can easily be negotiated with the medical regulatory bodies. If the government approves that the master's degree should be adopted as a subspecialty diploma qualification, then I believe the regulatory bodies will not have much of a choice. I personally believe that this is very important. In IFE, we actually have a master's program in clinical psychology, and a number of our trainees actually go through that program along with their fellowship program. And that's another way of doing it, that those on the residency training program currently, some of them are actually going into master's programs in parallel with the residency training. That's another way of actually producing more specialists into particular areas. So I would fully support that.
Yeah. Excellent. Thank you very much. Before I ask you one other question, before allowing you to catch your breath before going into your next presentation, Banji Adesoje has asked me to mention directly to you that Ondo State-owned psychiatric hospital now has 5 psychiatrists. So that's just for note. The other question here is an interesting question from someone called Sosmolu Shoinka, who says that could you comment on the finding that outcomes for individuals with severe mental illness are better in developing countries than in developed world? He feels this question has been challenged, but it seems to have held up to scrutiny. Is that something you might want to comment on?
I think if the services, if the facilities are inadequate, the outcome will also be inadequate. The facts of the matter are that psychiatric services are poorly developed in Nigeria as well as in most other developing countries. If the facilities are there, then the outcome will be better. I don't really see it as a major area of dispute. What we need to do, though, we don't have to go along and develop the same kind of facilities that in Nigeria, for example, as they have in the UK. I think we need to adopt whatever system will suit us best. And the policy, the 1991 policy, to me, will answer the needs of our country much better than the current system that is being practiced, say, in Australia or the UK, and so on.
Excellent. Thank you very much. I'm going to ask you to go into your next presentation, Professor Makanjuola, but one of the other series of questions that I think your next presentation may deal with is on the role of mental health care professionals in policy advocacy and influencing legislation to improve and strengthen the mental health care system in Nigeria. So that may fit into your next presentation on the role of government in mental health care delivery, which I would invite you to start now.
Okay. Thank you. This next phase is fairly brief because I think I've covered most of the subject in my earlier presentation, and the answer to what the government should be doing will be fairly obvious. But I want to start by highlighting the Mental Health Global Action Plan developed by the World Health Organization and which has been adopted by Nigeria. The MHGAP plan, which is how it's called for short, it doesn't mean gap, but it does address a gap, even though it doesn't actually mean that. It addresses the gap in the gap between the need and the actual provision. But it actually stands for Global Action Plan. It has 4 main objectives, but I will emphasize the second. The second objective of the MHGAP program is to provide comprehensive, integrated, responsive mental and social care in community-based settings. Comprehensive means available to all. Integrated, it is present and organized through the 3 tiers of the healthcare system. Community-based, that's all that I've been talking about earlier. If we're to implement the MHGAP, the answer is fairly obvious. Next one. And the first thing the government needs is to implement the 1991 mental health, the revised 1991 mental health policy. We have a policy. What we need is to implement that policy. That policy is for a mental health care system founded on a firm base of primary mental health care, supported by appropriately developed secondary and tertiary care facilities, and with an effective two-way referral system between the 3 tiers of healthcare that works in both directions. We need to implement this policy, or this revised policy. Next one. We do not have a mental health law in Nigeria. The laws that we currently operate are based on archaic 19th century laws that were passed on to us by the British. I think there was a question being asked, how do we advocate for changes in the law? The mental health bill was developed and passed by the Senate of the last government. It was actually developed by a team that included Dr. Makanjuola, the late Dr. Makanjuola. He was a senator, and he was instrumental to ensuring that that bill was developed and passed by the Senate. But that's where it ended. It was not taken by the House of Representatives. And what the story I have is that the reason it wasn't taken by the House of Representatives was that money did not change hands. That is how our country was then. I do hope that our country is changing now. We need to mobilize all concerned to pass the mental health bill into law. That's a job for all of us. It's a job for the Association of Psychiatrists in Nigeria, but all of us who are involved in mental health care need to get behind and mobilize to ensure that the mental health bill is passed into law by the present government. Next one. Well, I've addressed the issue of funding. I guess the current expenditure on mental health services is a bit more than 4% now, but I'm sure it's not much more than the 4% that it was in 2006. We need to improve the allocation of resources for mental health services. And we need to ensure that the use of those resources is properly prioritized. As I said earlier, if we spend all that money on paying the staff of neuropsychiatric hospitals, we're not going to get very far. we need to expend our resources on implementing the 1991 mental health policy. Next one. The government needs to recognize the importance of mental health within the healthcare system. Right now we have a mental health desk in the Federal Ministry of Health. That desk needs to be expanded into a mental health department manned by mental health professionals. And in every state, there needs to be at least a mental health desk. We need to implement that policy. I cannot say this too many times. Firm foundation, primary mental health care, supported by secondary and tertiary care, appropriately developed, and with a functional two-way referral system. I'm nearly there. As I said earlier, most of the services that we currently provide are secondary care services, general psychiatry. And for this reason, we need to address the development of tertiary care services, child and adolescent psychiatry, psychiatry of later life, forensic psychiatry. And finally, we need to stigmatize psychiatry. Next one. We need to destigmatize psychiatry so that when Nigerians think about mental illness, they will not equate it with vagrant psychotics, with people roaming the streets, or with people who have no hope. Mental illness is a medical disorder. It is eminently treatable, and we need to educate all Nigerians that mental disorder is a treatable medical condition. Next and last slide. I want to thank you all, and I wish you all good mental health. Thank you.
Thank you very much, Professor Makanjuola, for those two very interesting presentations. Again, as you can imagine, a number of questions which I think you were answering. But there's this particular one that was sent in earlier by Dr. Obindo James Taiwo. And I wonder if you could reflect on this. The question goes along the lines of, what are your comments on the proposed mental state assessment of all public officers before appointment? If they could go for mental examination, is it wrong to include as part of the examinations required a mental state assessment? I know that may sound a bit controversial, but I thought it would be something that is of interest to many people on this webinar. So I would really welcome your comments on that idea of a mental state assessment for all public officers before appointment.
It's a difficult question to address because there are many aspects to it. What we need to do is to ensure that we do not promote stigmatization of mental disorder. So if an assessment of the person's mental health is included within the medical assessment, that should be okay. It should then be regarded as just one other aspect of the medical assessment. Just as we're examining their cardiovascular system, we're also examining their mental system. But I do need to point out that many highly successful world leaders have had mental illnesses. Churchill had a bipolar affective disorder. He was one of the greatest leaders this world has seen. And for this reason, I want to also advise that we should not, on the basis of mental illness alone, exclude somebody from office. One area that I am concerned about, although I'm not too sure how we're going to be able to get to the root of that, is that we should try and screen out all the psychopaths. Psychopaths are currently, they've renamed psychopathy as dissocial personality. These are individuals whose behavior is self-centered and cruel and evil, and they don't mind who they kill or hurt in order to achieve their ambitions. There must be some way of actually excluding psychopaths or dissocial personalities from government. Hitler was a psychopath. My guess is that some of our past Nigerian leaders, I will not mention them, I know of at least one who definitely had a dissocial personality. It's not an easy question to answer, but I hope that the few points I've made will at least be of interest to you.
I have no doubt that that is the case, Professor Makanjuola. Thank you so very much. Without further ado, I'd like to move that very seamlessly into the second part of Professor Gureje's presentation, and he will be talking about the state and the role of research in mental health care development and delivery in Nigeria. Before I invite Professor Gureje to do that, I have already indicated on the chat that I'm mindful that we are going to overrun, and I think it's absolutely appropriate that I apologize as early as possible that we are going to overrun. But I hope people can agree with me that I think the conversations have been so insightful that I don't mind us overrunning. But please feel free, if you do need to leave at any point in time after the 1.5 hours that we already indicated, please feel free to leave if you wanted to. But please do hang on to see the end of it if that is possible. Professor Gureje, may I ask you to please carry on with the second part of your presentation? Thank you.
Thank you very much, Gureje. Can I have the second set of slides on, and hopefully I can do the changing from here. Right, so I will be talking about the state and role of research in mental health care development and delivery in Nigeria. And in doing so, I will give a brief outline of the profile of mental health research, the constraints of research, the role of research, and the way forward for Nigeria in terms of making an impact in this area. Now, the profile of research in Nigeria, one thing to say very clearly at the beginning is that mental health research has always been very buoyant in Nigeria. In fact, you would say that considering the number of psychiatrists in the country, as variably presented by Professor Makanjuola, the level of research in Nigeria actually is so surprising in terms of its impact, in terms of how it's brought the country into the limelight. So we haven't really done badly when it comes to making an impact, especially in regards to when you set it in the context of our number. The early studies, by the nature of things, focus generally on descriptive cross-sectional psychopathology. So we had studies on delusions and other cultural and other phenomena, especially from cultural perspective by Professor Lambo. We have the very important study of background psychosis by Professor Asuni, and problems of conduct disorder or behavior in children by Professor Latawura. These are general descriptive cross-sectional psychopathological studies. Later on, we started having longitudinal phenomenological studies examining the nature of some specific disorders and their outcome. And in this regard, the important studies by Professor Makanjuola on psychosis and mania, especially the one in which he described monomania, repeated presentation of manic episodes without intervening depressive episodes. These are all very important studies and among those early efforts about Nigeria. Of course, we can't but mention the very landmark ones and the Cornell Arrow study, the comparative study among Canadians and Yoruba conducted by Professor Lambo and his colleagues, stand very much out of the park because they use identical methodology, and it was really one of the first studies to show that Nigerians, or indeed Africans, had the same kind of vulnerability and pictures of mental disorder as did the Caucasians. One of the very early repudiation of claims made by some foreign psychiatrists before that either that Africans did not have depression or they didn't have well-developed frontal lobe, and so they couldn't have obsession, and those kind of claims really that were made by those people. This was one of the studies that set out to debunk it. Later on, of course, we then had this participation in very major collaborative studies, and some of them conducted in the context of WHO coordination. I have just mentioned the international pilot study of schizophrenia and the 10-country study of determinants of outcome of severe mental disorders. These were really landmark studies conducted in the 70s and 80s. And they established Ibadan, especially University of Ibadan internationally, in the global mental health research field. Rigorous epidemiological methods were employed, and the findings are supposed alluded to by one of the people who asked questions before, suggesting better outcome in developing countries for people with schizophrenia, have sort of remained a sort of holy grail of schizophrenia research since then. And as the person who asked the question mentioned, this has been sort of questioned by people. People have questioned the claim, but they still remain a study that has not been very much repudiated by any strong empirical project after that. Now, more recent studies have focused on epidemiology of mental disorders among primary care attendees, student groups, selected samples, especially samples selected from medical, surgical, and gynecological populations. These are small-scale studies, but they've also been very important in showing the extent of mental health problems in the country, especially those that have been conducted in primary care, that have shown how important it is really to integrate mental health service into primary care in the country. We've also had few large-scale studies that have become very well known in the country, and among these is the one that the WHO coordinated in 15 centers across 14 countries, listed on that slide, and one of the largest studies in primary care in which they use similar ascertainment procedures. Again, very important in terms of how it was able to set the country in the context of other countries around the world in regard to the prevalence of common mental disorders. Subsequent to that, now we've been having large community-based studies, the Ibadan Indianapolis Dementia Project, a very important study of dementia, which actually was funded continuously for 20 years by the U.S. National Institute of Aging, a very important attestation to its preeminence in the field of dementia, which was initiated by the late Professor Gureje and Professor Hugh Henry in the Indianapolis. The major finding, at least one of the most significant findings of that study, which was to show that dementia was less prevalent among Yoruba Nigerians than among African Americans. It's been a very widely cited research evidence for the fact that dementia does not have a similar occurrence across across cultures. The Nigerian Survey of Mental Health and Well-being, the largest community-based study in Nigeria of mental health conditions, in terms of coverage, in which more than 6,000 adults were assessed face-to-face and looking at a range of disorders, not just one disorder, but also looking at antecedents and consequences, what might have predisposed people to having these conditions and what might have been the impact of those conditions. Another very important study now, part of the World Mental Health Service, in which probably more than 200 papers have been written in various aspects of mental health disorders across the world. So the findings have provided an important policy relevant information on mental health service in Nigeria. So when people are thinking in terms of policy and coverage and prevalence, that is the only source that we can now refer and take recourse to in terms of getting empirical evidence. Subsequent to that, the Ibadan study of aging conducted this time in southwest and north central regions of the country, another large population study among elderly Yoruba speaking Nigerians aged 65 years and over, with more than 2,000 people assessed. Again, the findings are provided information on the relationship between mental and physical disorders and the elderly, because that study was not just about mental health conditions, but also about common physical conditions, and also the consequences of comorbidity between the two. So quite an important large study coming from the country. Some ongoing studies now include several ones determining or testing the feasibility of scaling up of mental health service through primary care. Several studies built around the image gap concept of delivering service. And of course, we also have quite a few large controlled, randomized controlled trials. It's an area which have really relatively been less explored in Nigeria. Randomized controlled trial, which of course we know as the standard for testing the effectiveness or efficacy of an intervention. So we have a randomized controlled trials of intervention for depression in adults and also for perinatal depression among the perinatal women. Have a large study on randomized controlled trial testing the effectiveness of collaboration between traditional faith healers and on the one hand and biomedical providers in the provision of care for severe mental disorder. Another very important question about can traditional and faith healers work hand in hand with biomedical providers in the care, as we have shown in the previous presentations, the importance of these healers in our system. But there's still the question about how much integration can be achieved, how much can they be brought into the public system, and we can only do this on the basis of empirical evidence. So this randomized controlled trial is set out to test that. And of course, we have studies devoted or focused on assessing how to strengthen the mental health system in the country. So quite a few large studies have been conducted, and some very important ones are ongoing in the country. And the funders come from funding has come from a variety of sources. Grand Challenges Canada, several studies been funded by them, Medical Research Council UK, DFID UK, Wellcome Trust, funding many researches in the country, the IDRC in Canada, the National Institute of Mental Health, and National Institute of Aging, as I mentioned before, European Commission, Australian Commission. All of these really attest to the competitive nature of the research programs in the country. You wouldn't be able to get funding from these sources if you didn't have very competitive research questions that you're addressing. But what's very significant in this is also the lack of national funding bodies on this list. So you have a variety of external funders helping to advance the cause of mental health research in Nigeria, but very little is actually coming from within the country. In spite of all this, despite of this considerable past and current efforts, large gaps remain in mental health knowledge in Nigeria. We have a gap that really typifies the well-known problem of poor funding or poor support for research in the third world or in developing countries. So as shown on this slide, less than 20% of the world biomedical research is devoted to about 88% of the world population residing in developing countries. So there's a big gap in terms of what is required to be done globally, a big inequity in terms of funding of biomedical research in general. Less than 10% of the fund available for health research globally is devoted to about 90% of the global burden of disease, most of which is in the low and middle income countries. So there is a reflection of that inequity in the country. But specifically, Nigeria also has its own peculiar problem on coordinated research, basically because there is no nationally defined priorities or incentives. If you don't set national goals and nationally accepted questions, then the research will continue to be uncoordinated, everyone doing various things, but really very little of it addressing the core questions that the country may really need to address. So we continue to lack a clear and robust plan to create centers of research excellence where critical mass is nurtured. We cannot really advance research in any area of medicine or in fact any area of human endeavor without creating those centers of excellence where the critical mass of people are nurtured to advance knowledge. We haven't been able to do that, basically because of those inadequacies that I've just mentioned. So we have failed to invest imaginatively and consistently in health research. As I've mentioned, no institutions are currently in existence in Nigeria established solely to fund competitive cutting-edge research in a transparent manner, not in a disjointed manner, where people will put up your proposals, they will be assessed transparently, and the most meritorious proposals are funded. Basically, some of these will be around nationally defined goals and targets. We don't have that yet. But good research is needed, irrespective of the fact that we kept on ignoring it. We need it to support evidence. We need it to have evidence-based policy. Even though I know that other considerations come into the formulation of policies, I mean, like political reasons and inequity and all of that. But indeed, you cannot really have evidence-based policy without robust research evidence. We also do need to have good research to drive development. The link between research and national development is often lost on our policymakers. But that's established everywhere, that in order for you to really maximize your potential in every area, you need evidence, you need and locally generated evidence. And of course, we need to improve the health and well-being of the population, of the people, which is really the ultimate goal of health research. If you don't also have ways of doing this, for example, a number of tropical diseases and local conditions are now completely neglected because no one is interested in Western Europe and North America to address them. And if you don't have funding and you don't have a targeted focus on addressing those issues locally, then of course they just get neglected. That is of course the situation also with mental health care and mental health research. So the area that are in need of particular attention, I just list a few on this slide. Community-based epidemiology, we still need to be able to track trend of diseases and offer suggestions on how to respond to the challenge. Is depression increasing? What is happening in the affected areas of terrorism in the country? What is the outcome? What's happening to those who are internally displaced? Those kind of features we need to address. Intervention studies to identify cost-effective interventions for disorders that have high burden of on the society. We need to be able to have locally validated intervention that are appropriate to our setting. Implementation research to actually see how some of these things fit into our setting, how some of these things fit into our health system, into our routine care. How can we make some of these interventions work within the primary health care system? And of course, health system research to assess the facilitators and barriers to good health system performance in the country. These are some of the very important questions that we need to address, and also still re-emphasize on this next slide. Epidemiological studies, studies of risk and protective factors, cost-effectiveness trials of interventions. How much does it cost to provide this particular intervention relative to this other one, so that people can make informed choice about which of them to go for. And health system and policy research to address scaling up of services, especially in the context of sparse specialist resources. We need to be able to see what are the barriers and facilitators for tax sharing with non-specialists. What is the effective way of training providers or primary care providers? What is the effective way of providing supervision for them? What is the effective way of ensuring that the skill they acquire remains sustained? How frequent should they have refresher training? All of those questions that can only be addressed through research. And of course, like I mentioned, we need critical mass of academic psychiatrists to continue to push the frontiers, improve funding, especially including career development grants for early career professionals to develop appropriately and contribute to the evidence available. Active and mutually beneficial collaboration, of course, is always needed between the South and also between the South and North. I mean, I'm not talking about South Nigeria, and I'm talking about South in the world and North in the world. So between the developing and developed countries, we need to continue to find ways of facilitating those collaborations for the mutual benefit of both sides. I think that's it. Thank you very much.
Thank you very much, Professor Gureje. That's really, really interesting. There, again, there's so many questions, and I'm struggling to condense them into themes, but I'm doing my very best here. There are three quick questions that I'd like you, I'm going to put them out very quickly. I'd like you to reflect on. Because some of the questions don't fit perfectly into your most recent talk, I'm also going to invite Professor Makanjuola to make comments if he likes on some of the questions, because I think they're quite general and broad. The first one is on this question was raised by Femi Adebajo on this webinar. He talks about some of the challenges with randomized control trials, and whether there is a place for more pragmatic design methodologies, given the potential limitations of randomized control trials in the real world. So, Professor Gureje, I wonder if you might want to reflect on that issue of how relevant and practically useful randomized control trials are in the field of mental health care research in Nigeria. The other question was raised by another participant here, Adana Wanguma, who talks about what we think about mental health training for religious leaders, given that what we know about some of the mental health issues in Nigeria is that people tend to resort quite significantly to religious means of solving some of this mental, and if in fact there's a place for mental health training for these religious leaders. And again, finally, a very important question, I think, is about the role of health professionals in the diaspora on improving and strengthening the mental health care system in Nigeria. So this question was raised by Professor Aliko Ahmed, who is on this webinar, but also it's also something that's been hinted at by a number of other participants. So could you just reflect on the RCT issue, mental health training for religious leaders, and the role of health professionals in the diaspora on strengthening the system before we go into the final presentation for this session?
Oh, thank you very much. Yes, I will quickly do that. In the first question about triad and RCT, yes, of course we do know the limitation of RCTs and the fact that they don't always address effectiveness. So it's very important to be aware of those limitations in advocating for their conduct. But also, there are two issues related to that. That is, we still do not have a higher way of generating evidence than RCT. So that in spite of the shortcomings, the strength of the evidence generated by RCT is still among the strongest. But what people have done, or people are doing, is actually to ensure that in the design of RCTs, they also bring pragmatic considerations into those designs, so that as they are being implemented, we also think in terms of contextual factors and real-world factors that may make them actually fit into day-to-day practice, routine practice. So there's no particular reason to not do them because of those their shortcomings, because in fact some of those shortcomings can be addressed in their design. The next question about training of religious leaders, yes, that's true, but I think we made this point in this series of presentations about the wider need for enlightenment of the general public, the wider need to sensitize people about the nature and the causes and the treatability of mental health conditions and so on. So religious leaders, of course, will fall into that. But in fact, those who are also practicing healing, religious healing, faith healing, we need to be even more targeted in those kind of activities to improve their skill and to improve their knowledge, especially in regards to addressing some of those inhuman practices of harmful practices of shackling and beating and all of that takes place not just in traditional healing homes, but also in religious healing places. So there is a need for their training. And as I mentioned, one of the studies and currently going on in the country, which is this testing of collaboration between traditional faith healers on the one hand and biomedical providers, of course, has inherent component of training of those healers within that context. So I do very much agree that that's an essential thing to do. We can't ignore them. They are very much everywhere, and in fact, that's again, as Professor Makanjuola showed, in the pathway to care, 70–60% of people with severe mental disorders will pass through these people. So we do need to ensure that these people receive the best possible care within these facilities. Role of diaspora professionals. In my last slide, I emphasized the need for collaboration. I emphasized the collaboration between countries in the south and also between countries in the north and south. And of course, one very good way of facilitating those collaborations is actually the people who are diaspora, natives of the country. We are trying to trying to establish collaboration with another country. For example, if Nigerians are desirous of establishing collaboration with UK or British researchers, then of course a very effective way of entry will be using the Nigerians in the UK, so they can facilitate that kind of collaboration. But they can also make direct input back into the system. What the Public Health Foundation is doing, this webinar is very good, it's an example of that. But we also have settings in which people actually come on a regular scheduled basis to go and deliver lectures, to go and give service. We know that that's happening, for example, with mental health professionals in Ghana. It's been happening for many years. They have a group of them that come from Canada and UK and the US, and they come to Ghana to deliver lectures in their medical schools and their postgraduate students. And the building of capacity in Ghana has been so much influenced by what these people are able to provide, because Ghana itself, at any given time, we probably have about 8 or 9 active psychiatrists who can possibly do very little. So there's no doubt at all that to the extent that we're able to tap on the resources for people in the diaspora, to that extent we will be able to maximize some of those collaborative possibilities that I mentioned before. Thank you.
Thank you very much, Professor Gureje. Professor Makanjuola, I'm mindful. I thought you wanted to say something. But would you want to say something, or do you want us to move on very quickly to the last presentation?
Was there a particular question you wanted me to address?
Particularly the one on health, the role of health professionals in diaspora. If you had any other thing you wanted to add to what Professor Gureje had mentioned, if not, that's fine.
I think we can go on to the next one. It's
Excellent.
Okay.
All right. Thank you very much. I think thank you so far, everyone, for your patience. Mindful that we have overrun, but like I said, I'm really enjoying and getting a lot of insight from this. Without further ado, I'd like to welcome our last presenter for the day, Mr. Egwu Chiijoke. I know you have only 7 minutes, but I'm really looking forward to what you're about to say. So, Mr. Chiijoke, over to you.
Thanks so much, Gureje, for such coordinated and far-reaching moderation. To my co-panelists, I'm humbled by the height of your research. To the attendees, participants, thanks for buying into the future of people like us who have once eaten from the dustbins of the streets. I was given guidelines or schedule on practical highlights of my personal experience as a former mentally ill person in Nigeria. The first reference point is a brief synopsis of illness and the extent to which service user and family and others as Kelechi was able to point out in my citation, I did to experience varied occasions. The first was the second was during a toddler student then University of Nigeria. So really, mental health highly mysterious from traditional definitions that the Western world has made in terms of research that in that regard. But considering our African background, attachments, and then superstitious beliefs, but that has come and gone. What was your experience of being? I was not totally minor to remember some sharp and occurrences during those periods. One was that during my treatment, I was always moved in my spirit when I was shown love and care and a kind of attention. And then secondly, that also helped me because the second phase of my mental I didn't have direct contact, not until after to trace me down to Lagos and recovered me. So I think what benefited me more was the I received from my carers. Then of your care supported in what aspect of your care seemed to make your health recover?
Is Chiijoke still there? Chiijoke, have we lost you? Is Chiijoke there, or have we lost you?
He's still listed as being on the panel. Might be having IT challenges.
Okay, I'm just gonna check one more time with Chiijoke if we have lost him. I'm mindful that the audio has in the with Chiijoke's presentation has not been excellent, and that may probably explain why there's a chance we have lost him. Again, can I just check, is Chiijoke still with us? Chiijoke, we can't hear you if you're still there. Okay. I think I'm gonna have to, having checked about thrice now, if Chiijoke is still, I think I can safely conclude that we may have lost Chiijoke, and for that I am terribly sorry, and obviously he's probably facing some IT challenges from where he's calling in from. And I was already, absolutely enjoying the reflection on his personal experiences of mental ill health and his suggestion that the quality of care, the personal care that he received from his carers made a substantial difference. I would have loved to hear the end of that presentation, but I think you all share my disappointment, but I think that disappointment will be very easily overridden by the absolute fun that we have had this afternoon with the very insightful presentations from both Professors Gureje and Professor Makanjuola.
Can I just add quickly that we have a report from Chiijoke that will be sent out with the presentations from this webinar that will summarize his experience as well. So it's not all is not lost.
Okay, thank you.
Yes. Yes. Okay. So the next is advice to fellow sufferers. My advice to my fellow sufferers is to draw inspiration from within. Draw inspiration from within you. That's the only advice I have for them, because then the next is the service providers. They should show the mentally ill persons the light. When you show the mentally ill persons the light, as in the reason why they should not be in that condition, it inspires them. Then for the government, they should create an enabling environment, especially in terms of adequate legal provisions and then positive policies that should re-engineer our mental health concerns in Nigeria. Thanks.
Thank you very much, Egwu. We're really grateful for that. I'm not sure you were aware that for a significant part of your talk, we didn't hear you. You went silent, and then you came on toward the end. But in any case, we really found valuable the segments that we were able to hear. And I think every other participant, I think we've been told that we will see the transcripts of what you have talked about. So I was going to invite, obviously I did hear, some elements of what you said in relation to almost advice for government, advice for the individual sufferer, but also advice from mental health carers. I was going to invite both Professors Makanjuola and Professor Gureje if they had any comments, however quickly or brief, about Chiijoke's presentation. If you wanted to just make that comment before I brought this to a close. Did you have any comments, Professors Gureje and Makanjuola?
Well, I mean, it's fortunate that we weren't able to hear Chiijoke very clearly, because I think because of the connectivity problem from where he's speaking. But that perspective will have certainly, enlightened a lot of people. This is someone who's gone on to achieve, very much in this area of chosen interest, and to set that in the context that even when you do have severe mental disorders, you can be treated and you can get well and you can move on in life and do well just like anyone else. That's a very important message that I think should be drawn from his presentation. Thank you.
Excellent. Thank you very much. Professor Makanjuola, did you want to?
Yes, I think 2 quick points. The first, I want to emphasize what Professor Gureje said. Having a mental illness did not prevent you from making your way in life. I keep getting families come to me and they say, can you still study? Because they think that studying is too much for the brain of a person who's had mental disorder. It isn't true. We really need to encourage them to actually achieve their potential. And I think that message was very clearly stated by Mr. Egwu. The other thing is that I listened to what he described about his experiences, and we as health professionals always need to try and empathize with what the person is experiencing. We need to be looking at the symptoms of mental disorder, not so much in terms of clinical terms, hallucinations, delusions, passivity, experience, but in terms of what that person is experiencing. And when we can empathize with what that person is experiencing, we're better able to treat him, to communicate with him, and work with him to achieve a recovery from his illness. Thank you.
Thank you very much. I'd like to bring this webinar to a close by saying a big thank you to Professors Gureje and Makanjuola and Mr. Egwu for this very informative session. I mean, the wealth of information that I have received today, and I hope it is the same for everyone online, has been incredible. And I just want to thank you for taking your time to share with us your expertise. That's really helpful. And Mr. Egwu, thank you. There are a number of comments that have come in already of people being inspired by your courage and resilience, and actually showing that it is possible, irrespective of one's state of mental health or experience of mental ill health, to go on and be resilient and make something good out of one's life. And that is an interesting, powerful story for most people. So I would like to thank all 3 of our presenters this afternoon or this evening, wherever you are. So thank you very much. I would like to remind everyone who's been online that we have recorded this session. So the recording will be available via the www.phfn.org website. An email will be sent to all registered attendees in about a week with the URL for the recording. Also, we have a short electronic evaluation that will come up in a few seconds. So please take a few minutes, I ask you, please take a few minutes to complete the online survey to provide your feedback on this session. As you understand, feedback is so important for us to be able to learn from this session and be able to improve subsequent sessions. I would like to sincerely thank Professors Gureje, Makanjuola, and Mr. Egwu for today's very encouraging presentation. That concludes this webinar, and thank you for your participation. Have a good evening.
Thank you.
Thank you.